A dislocation of the elbow is often associated with an immature annular ligament. The mechanism of injury can be the same as you would see for an acute UCL sprain, which is the hyperextension or valgus stress coupled oftentimes with rotation. When this happens, the olecranon process is compressed into the olecranon fossa. Both the ulnar humeral and the radial humeral joints will dislocate as a pair, and the vast majority are going to dislocate posteriorly. 60% of elbow dislocations have associated fracture of the medial epicondyle, radial head, coronoid process, or olecranon process. This is a very painful injury. You're going to see a very prominent olecranon process posteriorly, and the isosceles triangle is disrupted. The olecranon and radial head are going to be palpable posteriorly, and you're also going to see a slight indentation in the triceps that's visible proximal to the olecranon. There will be a grotesquely positioned arm with an angular deformity, rapid swelling, total loss of function, and the arm will be held in flexion with the forearm appearing shortened. The only special test that you can really use if you need to is the isosceles triangle not being intact. Neurovascularly, a nerve palsy is common, although it is transient. You do want to check the radial, ulnar, and median nerves as well as the brachial artery. An X-ray is going to be performed to rule out the fracture. Treatment-wise, you really do need to triage this injury and splint it in the position of the injury. A closed reduction is going to occur with a posterior splint being applied to prevent Volkmann's ischemic contracture. In the case of an elbow that may actually sublux, you can perform a posteriolateral rotatory instability test. When you are performing this test, the elbow will sublux when in extension and relocate in flexion. You're applying a valgus stress and an axial compression as that elbow is extended.